And thank you to the organizers for having me, and perhaps thank you for putting me at the very end so that I get to speak about everyone's presentation without hopefully boring everyone to death. So briefly, I've been asked to talk about a couple of things, and one is kind of the human rights implications of what we've been talking about here, and two is what are some of the community, civil society, and activist perspectives on what we've heard. So kind of first to begin kind of through the lens of human rights. And it's worth noting that that there's many long-standing human rights concerns that continue, that have been around for quite some time, and continue in the era of 90-90-90. This is not a big surprise. Chief among them, this question of choice, freedom from coercion, and making sure that that's real. And I put it up there because we need to be honest that is not always made real for people. My colleague Asia Russell, who couldn't be here, tells stories and is working on a project right now to try to document women in Uganda who aren't necessarily sure why they're on PMTCT and then fall off a cliff afterward, right? Who aren't invested because they haven't been given the information, and the choice to go on is not made real. So that has to be a transformative piece if we're to respect human rights going forward. We also heard data from Ambassador Birks about lessons from Jamaica, and there's a variety of them talking about discrimination. We also heard earlier today, right, about a kind of the key piece in Botswana around migrants who don't have access to ARVs. Discrimination is real and present, and we need to tackle it. And a third piece around participation is central to the human rights paradigm. Transitions that have been happening at PEPFAR have gone from a place where civil society and people most affected by programs had actually no idea about where the money was going to, and they're beginning to actually understand it, and it's making for better programs. We know that that's true. And we know that if we're going to reach 90-90-90, these human rights concerns are what make programs work better, right? That if you want marginalized people to show up, you have to ensure that they're protected. If you want people to be empowered to demand access, they actually have to have the information given to them and real choices made. And if you want adherence to be real, then you are dependent on people waking up every day and taking drugs. Millions of people around the world. That won't happen in the current system as it currently operates. There's often, I think, been a kind of a discussion when it comes to human rights and the kind of 90s targets as if they are in counter to each other. And I want to ask that this group really think about how do we, as boosters of 90-90-90, as supporters of treatment as prevention, think about the ways in which human rights protections are what's going to get us, especially to the people who haven't yet been reached. There's a reason why some of them haven't been reached, right? And if we know that we can implement human rights protections for approximately 1.5% of our budgets, if we know that that's true, then failing to do so is part of why we're not reaching a lot of the people that are out there. But I also want to talk about another way to think about human rights that I think is missing in a lot of our human rights discourse, which is the right to health. That at this point, more than half of countries in the world have in their constitutions a right to health. That every country in the world has signed an international agreement that guarantees the right to health. And central in that is access to essential medicines, of which antiretrovirals is one, as part of the minimum core obligations of every state. Right? And so these are some nice words, these should all happen, et cetera, et cetera. My argument, and an argument that's been increasingly made, is that this is no longer just about, as we know, treating the sick before they die. And so if that's no longer what antiretrovirals are about, then all of a sudden the human rights obligations of states have shifted dramatically. Right? If people living with HIV have the opportunity to prevent HIV transmission, if they have the opportunity to actually live longer, better lives through access to antiretrovirals beforehand, then that's actually a fundamental core state obligation as agreed to by every state in the world. We need to take better notice of that. We have a problem, right, which is that our guidelines almost everywhere in the world don't meet core minimum standards. Current WHO guidelines don't meet core minimum standards, right? Current guidelines throughout the world don't. Only 10 countries in the world today have actually implemented people's ability to access ART immediately if they want to, right? So that means it's a matter of policy that people don't have access to those drugs, right? And what we are seeing, though, is that there is an increasing new era of enforcement of these kinds of rights. That in Colombia, 100,000 petitions challenging government policy on health were filed last year, right? In South Africa, TB campaigners won a major judgment recently against the government. In Kenya, major victories against intellectual property rules that would have limited people's access, right? So I think states are increasingly opening themselves to challenge if they're not implementing immediate ART. And a core question, I think, for us and for the UN agencies is how are you stepping in to actually make that more possible, right? The UN has a huge human rights apparatus. Where is the discussion within the UN about the fact that people are not getting access to antiretrovirals as early as they can, as early as they deserve as part of their human rights? Also worth noting that part of maybe the reason for that is a pretty dramatic shift recently in human rights funding. Right? And so what I want to put on the table is this question that if there's a possibility of using human rights to forward, not prevent, but forward the 90-90-90 agenda, then we need to address the reality that many human rights organizations are actually being defunded and actually think about human rights interventions as core to the realization of these goals. So that is part one of what I want to say. Part two of what I want to say is to pose this kind of provocative question of whether we're in an era of rationing or in an era of scale-up. And what I want to put on the table right now is that we are living right now in an era of rationing. The system as it exists right now is one that rations. CD4 count staging now is rationing. There is no medical reason to do it, and therefore the reason to do it is because you can't afford or have not set up the systems to give people access to care. We can't afford it and we don't have systems that will do it is not a reason not to give people rights. And therefore, that same thing is true right now. And so if that barrier is there, it's one that we have to dismantle. But there's also a variety of other ways in which rationing is very real right now and rationing access to care that we need to dismantle. One, through failing to invest in testing, right? And that's been talked about substantially. But we need to acknowledge that sometimes, and we see this all the time when we work on policy and when we work with activist networks, that the fundamental barrier to access is that people don't know their status. And when activists go to government, the last thing that government wants to do is to dramatically scale up testing, right? So it's not that this is an accident. Right? We need to understand this as an intentional barrier in many countries to access to ART. Because if you don't scale up testing, you don't have to scale up ART nearly as fast. Right? So just understanding this as a barrier means that we have to have a very different approach to how to dismantle that. That's a barrier to treatment. It needs to be dismantled as a policy question. Rationing through poor use of funds, right? And so this has been a theme of a lot of conversations that have been happening recently where it is not equitable to put an equal amount of dollars in testing into a low burden area as into a high burden area, right? It is not equitable to fail to reach the most people you can because you want to invest in low impact interventions, right? This is not equity, this is a huge problem, and it causes rationing, right, of ART. But I do want to put on the table that alternatively, right, we have a real danger as we talk about focus and as we talk about things like hotspots. Because that too can turn into rationing. It can turn into a situation where some place is not high enough burden to get access to care, high enough burden to actually warrant a cost-effective intervention. And that's exactly the kind of work that the AIDS movement has dismantled, the idea that it's not cost-effective to go and reach certain people. And we need to be very careful about ensuring that that does not return as we move forward. The final thing I want to note is just this kind of question around rationing of models of care. The other kind of reality today is that rationing happens when people are put into systems of care that are not responsive to their needs. We know right now that programs that actually put ART into the community work better than programs that hope people will come to the clinic every week or every month or even every 2 months. We know that. So why are we piloting community-based programs? Why are we piloting adherence programs, right? There's a lot of evidence about what works. We need to change this. Not tomorrow, not 3 years from now. We have a real danger, right, that rationing effect that's happening is going to prevent the realization of 90-90-90. And if we don't actually roll out programs across the countries, it's going to be a huge problem. All right, so that's my downer. Sad, these things are happening, rationing is happening, it needs to change. But I think we need to be real about it because if we don't actually address the core fundamental rationing that's happening today, we can't be realistic about how to move forward and dismantle each piece of it. Okay, so an agenda. We have science, check. Congratulations. Thank you, scientists in the room. Hooray. This is a huge breakthrough. We are in a place that feels as transformative, and I think, both that Kate was saying this, that we are in this moment that feels so transformative, similar to what it felt like the last time people were in Vancouver. We're missing three pieces. We're missing policy, right? So we need WHO recommendations, and they need to come ASAP. We are in an era right now where WHO is falling farther and farther behind, and we're in a situation where if you walk into a clinic in Los Angeles or you walk into a clinic in Paris, you get access to ART. If you walk into a clinic in Jakarta, you walk into a clinic in Kampala, you don't, as a matter of policy, right? That has to change. But we also have to be careful and kind of push, and this is where I think folks in the room might really help, because there's a huge need to transform some of our institutions, right? That as we read some of the recommendations that we saw, for example, come out of the TRP from the Global Fund, it seemed as if they had never heard of HPT and 052, and we were deeply disturbed, right, to see some of the kind of things that are happening. So as we move our policy, we also need to think about the institutions that are implementing those policies. We need speed. Yeah, and everyone has been talking about this. We're worried that actually we're seeing in some countries signs of a slowdown, right? And so I'm not going to go into deep details, but where some countries are speeding up, some countries are not speeding up, and this is a huge, huge problem. Finally, we need money, right? And so I will be the one at the end of the day that says, by the way, we don't have enough money to do all of this. We cannot implement 90-90-90 on the current budget. Right? It's not possible. Global Fund replenishment will make or break whether 90-90-90 happens, and whether PEPFAR actually gets more money will also make or break whether 90-90-90 happens. Finance ministers have not heard the evidence that's been presented here. And so I present three humble proposals, right, for discussion and or ideally implementation. One, right, we need the scientists' roadshow. Right? So this morning we sat here and we heard amazing presentations that I was scribbling notes and trying to say, how do I get this into activists' hands, because ministries of health have not heard the search study yet, will not hear it a year from now. They do not read the peer-reviewed journal articles. So can we have a science roadshow where IAS and others bring these folks around and actually intentionally go from country to country, go to donors, sit with Congress, sit with other donors, and make this case really clear from the science, because it's incredible. Number two, we need an urgent donor conference. So it's time to start thinking about how to pull together donors and say we are in a different era than we were before. Right? There was the pre-Hart era, there was the post-Hart era. Now we are in a moment where we have the opportunity to surge ahead, but we don't have the funds and the political will to do it. But we can. And then finally, you all can sign a declaration. And so I will leave to Julio a little bit to introduce some of it, but this is part of, because we know that we can end the AIDS crisis, we know that we have a short period of time to do it, we know that everyone deserves antiretrovirals today, right? And we know that CD4 count doesn't make any sense anymore as a barrier to care. We are joining with IDSA and IAS and IAPAC and everyone else on this panel, I hope, to sign this declaration that actually puts that out into the public sphere, that we hope will get media attention, will get to ministries of health, so that it will be clear that the scientific consensus has shifted and it's time for policy to follow. Thank you very much.